Welcome, everyone, and thanks for joining us tonight for Ask the Expert. I'm Catherine, and I'm the virtual coordinator for the National Aphasia Association. The National Aphasia Association is a nonprofit organization whose mission is to promote public awareness and understanding of aphasia, to promote research that aims to improve the lives of people with aphasia, and to provide support to all persons with aphasia and their care partners. April is Occupational Therapy Month, and tonight we are joined by two wonderful occupational therapists, Kristin Nuckols and Becca Carr. They will be sharing how occupational therapists, or OTs, support the aphasia journey, and they're going to be spotlighting some of the new and innovative therapies and research for brain injury recovery. You can write your questions about tonight's topic into the Q&A section of your Zoom toolbar, and feel free to say hello or add a comment in the chat section. Kristin and Becca will try to answer as many of your questions as they can this evening. We might not get to all the questions, so if we don't get to yours, or if you think of another question, please email the National Aphasia Association at answers@aphasia.org. And now I'm honored to introduce our experts for tonight. Kristin Nuckols is a rehabilitation tech innovator and expert in telerehabilitation. She has been an occupational therapist for 17 years with experience in hospitals, clinics, academic research labs, and now as a startup co-founder. Her post-professional doctoral thesis described a unique and highly effective telerehabilitation model for adults with stroke using home-based robotic and sensor technology. Her startup, Imago Rehab, is bringing that vision to life and restoring function to adults with stroke across 6 states. She is also a wife, mom of 3 busy kids, and lives in the Boston area. Becca Carr is an occupational therapist with a background in the outpatient neurological rehab setting, working with patients with stroke, traumatic brain injury, MS, Parkinson's, ALS, and more. Becca is a certified stroke rehab specialist and certified brain injury specialist. Most recently, Becca is a therapy development specialist for Vivistim paired VNS rehab for chronic stroke. She is most passionate about stroke rehabilitation and educating the community about OT's full scope of practice. So welcome, Becca and Kristin. I will turn it over to you.
Thank you. Thank you so much for having us. Okay, let me share my screen. Okay, can you see that okay? All right. So today, Kristin and I are going to be talking a little bit about occupational therapy in the spirit of Occupational Therapy Month, which is April. We're going to talk a little bit about what neuro OT is, how it's different from other disciplines, and how it's different from different specializations within OT. So we're kind of going to talk a little bit about what is OT, where do you find OTs, what do we focus on, and then we can answer whatever other questions you guys have about OT or Kristin and I's practice in general. So what is occupational therapy? A lot of times when we say, hi, I'm an occupational therapist, people will say, but I'm not working anymore. I don't need help finding a job, because people think that occupation only means your job. And what we're referring to when we say occupation is meaningful tasks. So if you look up in the dictionary, it's going to say that occupational therapy is a form of therapy for those recuperating from physical or mental illness and encourages rehabilitation through the performance of activities required for daily life. So a lot of times OTs are referred to as practicing ADLs, activities of daily living, or IADLs, instrumental activities of daily living. Essentially, this just means things that you do every single day, getting dressed, taking a bath, brushing your teeth, and then higher level things like money management, driving, returning to work, things of that nature. An occupation, like we said, is just a meaningful activity, and that's going to vary person to person as our scope varies person to person. Whatever's meaningful to one individual may not be meaningful to another. We may have a patient who was a piano teacher and really wants to gain digit isolation, so they're able to teach their kids how to play piano. And we may have another patient who's not interested in music at all. So your practice is going to vary day to day and patient to patient. We do work alongside with speech language pathologists and with physical therapists to help patients and to individualize programs for people after a neurological event. Where can you find us? So it's more so, where can't you find us? We try to be everywhere because we are in every aspect of people's lives, from, like Kristin was saying earlier, from birth to death. Everything that you do within a day is something that we can assist with and help to retrain or compensate for. So we're going to be in every step of the care continuum post-stroke. You're going to find us in acute care when you're first admitted to the hospital, inpatient rehab, skilled nursing facilities, home health, outpatient, telehealth, within the community, in school programs, and also mental health facilities. Our goals are going to vary with each patient as they progress throughout their journey and as different things are more important to patients as they gain more function. People with aphasia living in the chronic phase, so 6 months and more, are probably going to encounter occupational therapists either in an outpatient rehab setting or maybe during telehealth visits with their therapist.
Okay, I'm gonna jump in too. Thanks for getting us started. So this was a great question that Maura posed to us to say, how can OT address, how can OT be applicable for people working with aphasia? Is working on someone's language part of our scope? And so, part of what we believe about occupational therapy is that it is a skilled service from birth to death for, babies as soon as they're born, to people in hospice, to folks with all ranges of conditions and experiences. So one's speech and the challenges that you are facing because you experience aphasia is integrated in every part of your life. And so that's kind of part of how occupational therapy fits in there. We definitely don't say that speech therapists work on speech and OTs work on your daily function and PTs work on walking. All of us work with people. And so we really just believe that, all of these kind of categories we have listed here, like gross and fine motor. So your larger movements and your smaller movements, returning to work, returning to driving, all of these tasks require a whole body and a whole person. So we definitely don't want to pigeonhole what the different disciplines work on. So some of this comes from the documents that explain our profession, like the OTPF, which is a 10-page document that explains exactly what OTs do. So I might explain a few of these words so that you can see how that fits into your life. Things like habits, roles, and routines are the different things that you need to do in the day, the certain things that you want to do in the day. I have roles in my life like being a mom. So I had to hustle home from my daughter's choir practice, brought dinner, gave that to the family, and then hustled up here to get on a webinar. So that really changed. Knowing that I had this role tonight of being a webinar presenter affected the rest of my day because I had to plan around that. So that's kind of how OTs think about someone's roles and how having, say, a stroke or another condition that affects your language, the roles that you play are really important in what your rehabilitation is going to look like. There's another one on here that talks about oculomotor function. So occupational therapists are trained to help assess vision, as well as try to help improve that in ways. We're not the ones, say, to prescribe a pair of glasses to someone. but we might do something like be able to detect if someone is missing part of their vision, say following a stroke. Our background is largely in strokes. I might just kind of use the word stroke here, but knowing that there's a variety of other reasons why people join this webinar tonight. Oops, turn my phone off. So something OTs do is, assess someone's ability to see their environment. Are they missing half? Are they missing, say, the right side? And then finding ways that we can help to improve that by a variety of strategies, like putting a sticky note on the right side of your mirror so you can scan over to the sticky note and then notice where the rest of the mirror is. So lots of ways that we can kind of provide assistance there. Return to work, return to driving. That's a big one. That's something I'd love to actually specialize in later on in my career. So I'm really interested in the return to driving. That's something I know in Virginia, it's sponsored by the state. I'd like to know other states as well, how they have different driving programs, whether they're private or not. Those at the bottom, Rebecca explained those a little bit. Self-care, taking care of your personal self, your activities of daily living, which are kind of the things you do just to get yourself ready for the day or to put yourself to bed at the end of the night. And then those IADLs, things that are a bit more complicated, like cooking a meal, purchasing the food, taking care of your pets, cleaning in your home, paying the bills, all kinds of like the other stuff that's still really important. On the other half, the right side of the screen, leisure activities are also part of your daily life. We should all be doing, we should all be making sure that we have time for fun and making sure that we have time to relax. So that's something that an OT might talk with you about. How are your leisure activities affected by the condition that caused your aphasia? I know I've was working with a gentleman last year who really wanted to return to fishing. And it was less about his aphasia and more about his one of his arms. He was having such a hard time steadying the fishing pole and then also doing the other tasks that were involved, like turning the wheel and fiddling with the little pieces that have to go on there. I'm not a fisher person. Weights and bobbers and stuff. But that's really important to him. And those skills that are needed for, say, fishing are also really important for self-care. So, all of these things are activities that we might work on in OT. Sleep hygiene is a really interesting one that maybe people wouldn't think, oh, an OT can help me with my sleep hygiene. Doesn't really mean being clean while you sleep. It means setting up a routine that will help you to sleep better. I actually have on a piece of technology to help me with my sleep, which is this ring on my finger. This is not a fashion ring. This is called an ultra-human ring, not a plug. They didn't pay me. This ring detects my activity. There's other ones like Aura. There's different companies that do this. It tracks my steps. It tracks how long I sleep at night. And if I get a really good night's sleep, it encourages me to exercise the next day, which is interesting.
So it's taking our job.
I know, right? Sometimes I listen, sometimes I don't.
Yeah.
The idea of sleep hygiene is seeing your sleep as a routine and seeing different things that you can do to make your sleep better, like turning off your phone at a certain time of night, reading a book instead, sitting with lamplight. So there's so many things that we can talk through to help improve someone's routine around sleeping. What else on the list here? Strength, range of motion, sensation. I think those probably feel pretty regular for people when they think about therapy. Those are sort of the things that probably come to mind. Definitely working on helping people to stretch when they're tight, helping them to gain more range of motion. We will bring more of that type of discussion up a little bit later with some more of our slides. Compensatory methods is kind of a fancy word for when something's not working, we might teach a different way to do that. So if somebody wants to, let's go back to the fishing idea. If this gentleman weren't able to gain the skills, say to hold on to the rod, A compensatory method might be to wear a waist belt that he could put the rod into. So using the waist belt helps him do the fishing, but it doesn't help, say, his hand and arm to get better. So there's like a trade-off there. You know, which one do you want to keep working on, the, you know, trying to make the arm function better? And in the meantime, you use the compensation of the waist belt. That might be fine. That might be the decision you make. And then maybe spend other time working on the arm instead. So that's kind of a decision we help people to make, whether they want to use a compensatory method and some equipment, as opposed to like re-engaging their body back into that task. And self-esteem and mental health. Absolutely. We're coaches. We're like, we're your coach, we're your cheerleader. We can be your best friend, we can be your worst enemy. That's kind of like, we play all the roles, because different people are motivated in different ways.
Mm-hmm. Absolutely. And that's kind of what is so fun and interesting about OT, is that you can work with one patient that may want to work on all of these things. They may want to work on just one or two, and that's going to vary depending on what stage they're in, what's important to them, and where they're wanting to go with their next step.
Okay, so I'll continue here a little bit. I'm going to focus on this phrase in the middle that's a little bit centered and larger. So I'm going to read it out and then I'll talk through it. So neuroplasticity is the brain's ability to form and reorganize synaptic connections, usually in response to learning or experience following injury. So at home, if you've heard the word neuroplasticity, raise your hand. I hope that all hands are raised. It's kind of a buzzword these days. Thank you, Maura. I see your hand up there. It's kind of a buzzword these days, neuroplasticity. And I've had patients ask me, you know, are we going to harness neuroplasticity? That's really what we do. That's the whole point of occupational therapists and other therapists working with clients to gain new skills. The way that happens is through a process of neuroplasticity. So that idea is that your brain can change. We're going to give, again, in some of our slides coming up, we're going to give some examples of how that process happens. Does that happen because the part of the brain, say again, let's say the person had a stroke. Did the therapy help that part of the brain that had a stroke to actually heal? Maybe. Did parts of the brain that weren't impaired by a stroke begin to do a job that we asked it to? Maybe. These are some of the questions that are a little bit fuzzy, and there are some ways to answer them, like having an MRI that you can take at the beginning, and then you do an intervention and then do another MRI, and you can actually see where the brain changed. But that's not really typical. So most people aren't exactly sure what happened. What part of their brain changed? We don't really know, but what we see are behaviors that are different. An arm that's more flexible or is able to do more tasks, or a walking pattern that's faster. So we see these behavioral changes in our daily life that tell us my brain changed. And hopefully we can identify kind of what was it that helped a brain to get better, helped a brain to change the way that it functions, and then we do more of that thing. So that's a lot of what I think Becca and I will explain a little bit more about our understanding about how we affect neuroplasticity.
Absolutely. And I think the thing that we're consistently reiterating when we're working with patients post-stroke or brain injury is we are working on your brain, and we're not necessarily working on your arm and hand or your leg because there's something wrong with your arm and hand or your leg, but it's the way that your brain and your hand are communicating. And we're trying to help them communicate better, and then try to do that over and over and over again until that communication becomes subconscious and it's remote and it's working for that patient over and over. So a lot of times patients will think that there's something wrong with their hand specifically, and it's always we're working on the brain. And I think once people understand that, then you're able to engage more and you're able to pay more attention and be focused on what you're doing.
We have a patient, and I've heard this a number of times, but I'll get into this more later, but my practice is a tele-rehab practice. So we don't touch our patients, which is really unusual. That's not the way that this is usually done. But because of that, it really helps our patients, our clients, to understand that they are the ones changing their brains. It's not based on my magical hands, because they're not actually magical. Our hands are not magical. The activities and the tasks that people do at home, that's the magic. That's how the brain changes. And we have a client who said a few days ago, she had a stroke about 4 years ago and has been doing therapy with us for a couple months. And she now knows where her arm is in space. And for 4 years, she's had no idea where her arm was. She couldn't really see it. You know, she had that visual impairment I was talking about, and she did not know where her arm was. But now she inherently knows where it is. And so that's a great step to be able to do something with it. But if she couldn't even find it, she didn't know where it was going to be. Was it going to be off the chair? Was it going to be in her lap? Was it on the table? She had no idea. She could not find it in her brain. So now she, using our therapist, education, has changed her brain to be able to find her arm in space. It's pretty crazy. And that I've heard that from many clients that have said, I have now found my arm again. You know, I've learned where it is. And that's not something I had heard in the past. So I think that's kind of a cool story.
It's amazing.
Yeah.
So
Okay.
something that we're always focusing on in occupational therapy is evidence-based practice. Where is the research? And everything that we're doing with a patient is based off of evidence. And we're not just doing it because it might be something fun to do, even though we do try to make things fun anyways, but there is always a reason behind it. So research is always evolving. And as occupational therapists, we're always trying to stay up to date with the latest research so we can bring the best care to our patients. Right now, a lot of focus is on what's called task-oriented training. So what that means is that it's task specific. So it might not look perfect, but what we're trying to do is complete a task. So we may be trying to bring a cup to the mouth if you want to be able to drink with your right hand again, but you might be doing it, might take more time, you might need more steps, you might need facilitation, but the goal is to complete the task as opposed to making the movement look perfect. And I know, Kristin, you do a lot of that with Imago as well.
Right. Yeah. And what I was going to say is sort of the difference, a task-oriented training, you could compare that to doing exercise. So doing an exercise, like do 10 of these, doesn't seem to have as much ability to change the brain as bring this cup to your mouth, right? So that's the task-oriented part, as opposed to let's just have you move your arm in space. There's the idea of salience. That's another kind of buzzword in our field right now. And salience means the importance of a task. We, again, from my practice, we have a bunch of videos of patients eating food, having the food on the end of the fork and bringing it to their mouth. And I swear, we don't tell them to do this, but every time the person gets that bite of often a banana, because it stays on the fork, goes into their mouth, they all do this. And it just says, you did the activity, you get the flavor of the banana, you get the feeling of success, you did it, you completed the task, you are working towards something healthy for your body. All of those things just make your brain excited, lit up, active, as opposed to doing movements and saying, oh, what number was I on? Clearly the brain is like, oh, this is boring. I'm not getting anywhere by just moving. So that's the purpose of task-oriented training. having that goal. Exactly. Life participation, Mara's putting in the chat. Participation in life rather than doing the rep to get the rep.
Right. And that ties right into occupation focus, meaningful. I had a patient recently who she was really struggling with doing that one small little button on the back of her romper. So we took really tiny puzzle pieces and she connected them behind her head, which ties into repetition as well. 100 little pieces behind her head. And it was really challenging and really hard. But then she sent me a picture the other day and she is consistently doing the button on the back of her romper. So it made her life easier. It's meaningful to her. And we weren't just having her do something that was a task just to do it. Like you're saying, Kristin, like just an exercise, a bicep curl. It's meaningful, it's salient, and it's going to change their life for the better.
Think there about the difference between putting those together on a table versus putting those together in the place where she needed to button the back of her shirt. So she can't see it. She might not be able to feel it. She has to get her arms in this lifted, rotated position. That's totally different than on the table. So that's a great example of salience. If she had only worked on it on the table, she might not be able to do it. But because you replicated the salience of the task, she learned how to do it. The brain changed. It's a great
First
example.
day, she was only able to do 11, and then she's able to do the whole pack over and over. So it's that repetition, that intensity, the dosage, and making sure that we're doing things over and over again to build those new pathways in the brain and harness that neuroplasticity like we were focusing about earlier.
An example I give of neuroplasticity also, I'm in the Boston area. We get some snow. We didn't get very much snow this last year. It was a little bit sad. But I give the example of neuroplasticity is like the first kid that goes sledding down the hill. It's a little bit slow and it's a little bit bumpy, and you hit a bump, you hit a patch, and eventually they make it to the bottom. But the 100th kid down the hill is flying. They're going so fast because that pathway has been created over and over and over. And so that's the first time this lady put the puzzle pieces together. That was the bumpy kid, the slow sled down the hill. And then by the 100th, she had refined that pathway so many times that she can button the button at home. She took that skill out of the clinic and put it in her house. And now she does that and it's no longer a problem. That's awesome.
I love that analogy. That's great.
Yeah. You're in Florida.
So I am. I'm like, wait, snow? You mean sand?
What would work in Florida? The first fire ant comes out of the
there you go. Yeah, right. So there's a lot of different things that we're going to harness to focus on these top 3 things. So there's a lot of different fun, new technology, new aspects that are being added into practice daily that we're going to see in both the outpatient and the telehealth setting. A lot of electrical stimulation. So there's external electrical stimulation, like neuromuscular electrical stimulation, which a lot of you, if you've been in outpatient rehab before, you may have used that before. It's going to cause a muscle contraction, some joint motion, or functional electrical stimulation, which is FES, which you might use if you're on a bike or if you're in an exoskeleton. And then Vivistim, which is the company that I now work for, which is an internal stimulation on the vagus nerve during high repetition task practice, which can be used in combination with a bunch of these different things as well. We're working on things like error augmentation and robotics, which sometimes those can go hand in hand. And error augmentation is actually the really mean practice of making a hard thing harder to help your brain. Because essentially it's, say you're sitting on the edge of the bed and you're leaning to the side because you have some weak core muscles. Instead of propping you up and making you upright, we might prop you further into the error. So then you have to overcorrect and get your body upright. So then when we remove that stimulus, you've kind of normalized. So it allows your brain to recruit more motor neurons in order to perform a task. So then when the resistance or the challenge is removed, you're able to perform it much easier, which feels like a very mean thing in the moment, but it's backed by science, we promise.
Yeah. So I've seen this on your Instagram platform, Neuro OTs, and just want to give like another example of that, because there was a good example recently where there was a gentleman he was laying down on the mat trying to lift his arm forward, and the therapist is pulling the arm backward generally. Yeah. They're using a TheraBand or something, and he's trying to go forward and the therapist is pulling backward. He's, really. So what do you think is happening there? I think we know, but I want people at home to think, like, why would that work? Why would that happen? That when the therapist lets go, the arm goes boing, goes straight forward. Kind of what we think is happening is that person is attempting to reach forward, but it's not working. So that makes their brain try harder. Oh, it's not working. Push forward, reach, and really builds up that pressure. So then when the error is removed, boy, they've got an amazing, strong signal that's going in the right direction.
Mm-hmm. Yeah. Mm-hmm. It's used a lot in gait training too. So if the foot isn't able to clear, they might put a weight on the foot. So you have to really hike it up and move it, and it becomes really challenging. And then you're able to be successful. And then as soon as it becomes easy, that's when we remove it and you're able to walk better. So it's used in a lot of different ways. And I know, Kristin, don't you use a lot of gaming biofeedback with your patients?
I do. Yeah. So my experience is in the robotics side, gaming, biofeedback, and CIMT. So I won't take too long because we still have a number of slides left. So, robotics is there's a lot of things that are called robotics that are not actually robotics, but my understanding of robotics is some kind of a mechanical tool that can help move somebody. And then it also responds to some kind of input. So if you try to move and the robot helps you, that's a great example of robotics. Something that you just turn on and it goes by itself is not necessarily a robot. I also think a robot has to have a motor, has to have something that makes it move. So there's often, there's some definite devices out there that have gaming. So the point of gaming is just to literally to make this more fun for you. So you don't have to think about, what number am I on? You don't have to count your repetitions. When you play a game, you're more focused on your score or, the scenario that's happening in the game. So the point of gaming is just to try to make this more interesting so you can get the repetition that you need to change your brain. Biofeedback is when you can see what your body's doing represented in some way. So maybe you're moving your fingers and on the screen you are growing a flower or something like that. So it's some like representation of what's happening. Yeah, seeing what your body is doing. Excuse me. Allergy season. And then CIMT is constraint induced movement therapy. So that's again kind of a long name for really encouraging people to use the parts of their body that are really affected, using say an arm. Every time you go by the door, you use that arm to open the door. Every time you need to eat a banana, you use your arm to do that. So it's like choosing all of these tasks to do with your arm. Yeah. Maybe we should keep going since it's 7:35.
Yeah. I know we could go. We could
do this all night, but
I know. So something that Kristin and I are really passionate about is once someone with a stroke or a brain injury reaches that chronic phase, oftentimes you're told that you're going to hit a point where you're going to plateau. There's nothing more you can do. You're going to have to compensate, learn how to do things differently, which, as we know, with evolving research is really not the case, that the brain is plastic and we are able to make change. It might start to slow down at some point, but it doesn't mean that we're not capable of change at that point. So a lot of times people will end up going to the hospital, going to inpatient rehab, maybe having some home health, and then not continuing further with something like outpatient rehab or with telehealth therapy. They think that maybe that's the end of the road for them. And we're always trying to continue to urge people to try more and challenge themselves, because you might surprise yourself with what you're capable of doing. So my background is in outpatient. Absolutely.
To try again. Just because you've tried before and maybe weren't satisfied with the result, try that with a different practitioner, try with a different company, try again. Because things have changed. The idea of intensity and repetition has really become the norm in our field now. It's really becoming more normal. So the therapy you get now is not going to be the same therapy you got 5 years ago. It should be different.
True. That's very true. It should be different because research is always evolving. So we're always trying to keep up with it. We're always trying to challenge our patients. If something doesn't work, you pivot, you try something else. Doesn't mean that you stop. It just means that we have to change something. It's a trial and error process always. There's things like telehealth, like Kristin has started with Imago Rehab. That's very individualized. It's in your home. It's very specific, and you're able to generalize it into your daily life because you are in your daily life, which sometimes can be challenging with outpatient rehab because you're doing a lot of simulation. There's a lot of really cool resources there, but it doesn't always generalize as well as something that's in your home. And then in that chronic phase, when patients do start to slow down, I started to see some patients with what's called Vivastim. So it's a vagus nerve stimulator implant. It's FDA approved, and it's paired with that high intensity task specific practice where a therapist is actively stimulating the vagus nerve. So essentially, this is what we're focusing on is there's a lot of great technology for patients with stroke in the acute phase. So, which is phenomenal. We're keeping patients alive. We've developed all this great technology and more patients are surviving. But unfortunately, what that means is that now we have a lot of patients that have chronic morbidities and they might not know exactly what to do or where to go. And sometimes they end up not seeking rehab, not getting the help that we need. So we're really trying to bridge that gap from transition home into either outpatient rehab or some other means, whether that be telehealth, whether that be community care, where you can continue to grow and develop your skills. So kind of like I mentioned neuromuscular electrical stimulation and functional electrical stimulation. How Vivastim works is it's an internal stimulator. So it's stimulating the vagus nerve, specifically the left vagus nerve. So every time the therapist does that, it's sending a pulse up to the brain, to the motor cortex, and it causes the brain to recruit more neurotransmitters for that function. Similar to what we were trying to explain with error augmentation, we're trying to cause the brain to recruit more motor neurons. It's essentially what we're doing here. So you're doing all those best practice things that we were highlighting. You're doing high repetition, you're doing task specific, it's salient, but now the therapist is stimulating while you do those tasks in order to kind of increase the ceiling of potential and to kind of once you hit that slower phase of growth in the chronic phase, it's trying to make that go faster and more substantial for patients because we're trying to help boost neuroplasticity and build those new pathways around the damaged parts of the area of the brain from the stroke. So a lot of times people will think that it's similar to neuromuscular electrical stimulation where it's going to cause your arm to fly up in the air, but it's all based off what you're pairing it with in rehab. So whatever you pair it with is what it will enhance. So do have great clinical research, and I won't, belabor this too much because I know research isn't always exciting to people, but I could nerd out about this all day. But essentially what this is showing is this is the Fugl-Meyer upper extremity motor scale. So it's just an assessment that we use to look at movement on the affected side of someone post-stroke or brain injury. And what this is showing is that patients that were in the control group that didn't have Vivastim on, weren't receiving vagus nerve stimulation, did make gains when they were doing high intensity rehab. It was about 6 weeks, 3 times a week. But the patients that had vagus nerve stimulation at the same time as the high intensity rehab made 2 to 3 times better gains than the patients that were doing high intensity rehab alone. And what I really like about this is that it highlights that high quality neuro rehab works. Patients still make gains, but essentially what Vivastim is trying to do is just heighten that ceiling and allow patients to make gains quicker and more substantially. And this study was great because it was triple blinded. So the patients, the therapists, and the assessors didn't know who had their stim turned on and who had it turned off. So patients didn't really know. So we know that the results are reliable because we were able to track that. Even patients post-study were able to cross over from the control group and have their VNS, their Vivastim, turned on, and then they were able to receive the same results as the initial VNS group. So it's not to replace anything an OT or a PT is doing. It's just added on top of their tool belt of things that they can use.
There's a question, Becca, about sham. That word is in research a lot, but it's a strange word to use. Can you just explain what the sham therapy is?
Absolutely. So it's kind of like placebo controlled. So it's like one patient is receiving it and one patient is receiving a fake stim. So you're getting a real stim here and then you're kind of getting a fake stim here, but you're not sure which one is real and which one is fake. So the patients receiving the fake ones and the real ones both were unaware, essentially.
Because everyone got the implant. They didn't fake
Yes.
the implant. Everyone had the
No.
device inside their
Yes.
body. They either were actually getting the stimulation or they were not getting the stimulation.
Yes, all
Yeah.
patients were implanted.
Yeah.
All patients eventually had their VNS turned on, so they didn't just get implanted and didn't have it. But initially, they were split into the control group and into the VNS group. The control group was just doing high intensity rehab. The VNS group was doing high intensity rehab paired with vagus nerve stimulation. So that's how they're able to tell which patients were able to progress quicker. But they were both under the impression that they were receiving the same stim. So that's kind of what that
Right.
sham controlled means. So it was done the same way.
Which,
I know
I know we're taking a long time. We want to leave a little time for questions. This is interesting to both of us, so we could do this for another hour. But it is interesting to me that the control is still a high intensity rehab, which is that's not traditional rehab. I see that in research studies. Sometimes they compare to a high intensity tabletop program. High intensity is not the norm. So we're getting there. We're getting to where overall, general therapy is now becoming high intensity. But I just want to point that out.
Absolutely, because it's compared to high quality, high intensity rehab.
Right.
They're all doing 300 to 500 repetitions. They're doing the same 6 tasks, 50 reps each, and they're doing them in the same order. So they're not just doing a regular 2 times a week, 45-minute sessions. Like this is 3 times a week, 90 minutes for 6 weeks. So imagine the VNS group compared to traditional rehab. I mean, that difference would be even larger. So that is a great thing to bring up. And it always blows my mind. And it's been really fun to see because a lot of the patients that I've been working with in the chronic stroke space that I worked with, say 5 years ago, now are finding out about Vivastim, and I know what their plan of care looks like, and I know how they progressed a while ago, and now I get to see them make huge changes in 6, 8, 10 weeks that they weren't able to make in a couple of years. So it's really emotional and it's really exciting because it's kind of just like this glimmer of like, crack the door open and there's a little bit of light for a group of people that have been told this is it, and we're just saying, no, it's not, trying to shift it.
There's a great question. I'll moderate. There's a great question about why is it the vagus nerve? Why do they stimulate the vagus nerve?
So the vagus nerve is kind of called the wandering nerve. So the vagus nerve is involved in a lot of different bodily systems. And it is the left vagus nerve because the left vagus nerve is 80% afferent motor neurons. So what that means is that the left vagus nerve is stimulating motor neurons that are going up to the brain as opposed to down to the body. So when we're working in neuro rehab, we're always trying to work on patients on the brain level. So what we're doing is we're increasing the brain activity via the vagus nerve during task-specific practice. So every time you stimulate the vagus nerve, sends a half a second pulse up to the brain, it recruits more motor neurons while you're doing a specific task in order to enhance the improvement there. So it's kind of used as a vehicle up to the brain as opposed to stimulation that's on a muscle and causing a superficial motion. This is all based off of your own motion and enhancing that. It's a good question.
Yeah. Okay. So I'll talk a little bit and we'll try to leave maybe 10 minutes for questions. So I'll tell you a little bit about Imago Rehab. We are a tele-rehab practice. We're open in 6 states, so we're not everywhere yet, but there are maybe some tele-rehab options where you are. Tele-rehab is not the norm, and it's not what I did. I practiced in the clinic, in the hospital system, and inpatient rehab and outpatient rehab for 10 years, and I had no intentions of doing tele-rehab. So tele-rehab, if you find it somewhere else, might be because you can't make it to the clinic that day and they're willing to see you for telehealth. But it's very unusual to have telehealth as the entire way that you're being seen. Because people believe that you need to touch people to make them better. You need to be the one doing the stretching. You need to be the one helping them move. But we're finding that that's not really true. What we do think is true is that people generally don't get enough rehab. Finding really good high intensity therapy is hard. Getting to therapy is really hard. And then if you found good therapy and you managed to get there, figuring out how to do that therapy back at home is also really hard. So what we're doing is a tele-rehab practice where all of your therapy happens at home. So you don't have to get there, you just have to turn on your tablet. And the carryover is automatic because everything we do is being done at home. So the whole point, I think, go ahead and switch to the next slide and I'll try to get back to some of this stuff. But that second part at the bottom where it says, how does tele-rehab work? The way that any therapy works is it has to be carried over. If you're seeing Becca in the clinic and you do the best, coolest, most useful task once, and you can't figure out how to do it again, what was the point? That was only, remember the one kid that's sledding who's just going down slow? He was that one kid and he goes one time, he's like, you want those kids sledding down the hill, right? That's our analogy. You want those practices happening so many times. So carryover is the whole point of therapy. And so if you look at my pictures there, that's a picture, it's a little kind of picture of somebody's house. So the stars are telling me they're at the table, that person has a therapy activity to do at the table. At the living room, there's something therapeutic. Maybe it's that person who's leaning over like Becca was talking about. And when they sit on the couch, they work really hard on finding the middle and sitting straight. So it's beginning to view your house as your therapy gym. It's figuring out, how does therapy actually make it to my house? How do I make my life and my home where I live and all the things I do, how do I make that therapeutic? So that's what we do in tele-rehab. We figure out, what can somebody do at home? What should they be doing? And then we help them figure out how to do it a lot of times. I think there's one, maybe there's one more. Yeah, I did make one more. Look at me. So kind of the ways that we do this. One way is what I've been talking about, this intensive home therapy. So embedding therapy into your everyday tasks. We do that just, kind of the same as you would in person, a couple times a week, one-on-one with your therapist. We also use digital therapeutics. Raise your hand if someone gave you a list of exercises or tasks to do on a piece of paper. How many of you lost it before you got home? So we're trying to change that. And a lot of the field is working on changing to make the things that we give people digital. So you put them on someone's phone so they can't lose it, right? Just like some of the systems you guys use, like Constant Therapy, other digital programs, right? So you can't lose the things you're supposed to do, and you get some help to remember to do those things. And then lastly, we use wearable robots, which there's one picture there. We got our exit from Harvard University working on that wearable robot, which means it is a robot that you put on your body. It senses your attempts at movement and then it tries to help you. So we're not on the market yet. We're still pre-FDA, which means we're still studying our device. Like Vivastim has already been approved by the FDA. They're implanting in people. We're still using our device with folks under a research protocol. So I think that's what we brought for you guys today. And we would love to, I think there's still a few questions. Maura, do you want to?
Yeah, thank you. Thank you, ladies. That was so much great information. I know Ask the Expert's going to have to become a 2-hour long event. But we'll try to get to a couple. Thank you all for the questions. And again, if we don't get to them, you can always email us at answers@aphasia.org. And Mara's going to share Kristin and Becca's emails in the chat as well, so you can reach out to them. We have some attendees with PPA, and I've gotten a couple questions about how this all applies to them. So primary progressive aphasia, what's the role of OTs, and how might some of this technology help them as well?
We're looking at each other like, who is going to answer this question? I will say, I don't feel like I'm a super knowledgeable expert about PPA, much more focused in the stroke realm. But like we mentioned, occupational therapy certainly is birth to death and anything in between. And so where we think a really good neurologic OT is, first of all, that's the person you have to seek out. Sort of an OT who's skilled in, say, hand therapy, makes splints for people after they've broken their hand or wrist. That's not the therapist who's going to be the most helpful. So seeking out somebody like Rebecca has some certifications like the stroke rehab specialist, brain injury specialist. Yeah, I don't have those specialists, but I don't have those certifications, but I do have my doctorate, and I focused on telerehab for patients with stroke. So find someone who has these type of certifications that really understands the neurologic client, and then we can help figure out help identify the areas in your daily life that are the challenges related to the PPA, and then tailor our intervention there. There's no one blanket answer that's going to make it better, but a good therapist will help to understand what it is that's your challenge in your daily life, and then what it is that you can and can't do, and help to bridge the gap there.
Right, exactly. I was going to say a very similar thing is that you see an OT who sees a lot of other patients with neurological conditions. They're going to do a thorough assessment with you. They're going to see what's important to you, where your deficits are, what you'd like to be able to do, and they're going to make an individualized program with you to reach those goals. So depending on where you feel like things are lacking or where you need to improve, they'll be able to come up with that in combo with your physical therapist and your speech therapist to make sure that you're as independent as possible. So a good neuro interdisciplinary team is always really key for someone who has a diagnosis such as PPA.
Okay, great. And actually, that's a good segue to the next. I'm kind of putting a couple questions together. It's about finding resources. So, what recommendations do you have for finding the OT that you're alluding to, who might specialize in neurological disorders? And then, in addition to the person, you've talked a lot about great technology. Are there a website we can direct people to, other places people can go to find those resources?
I think for some of the certifications, if you look up that certification, you can find practitioners for that. It's also another one. OT Potential is another one, where you can list your specialty within a website like that. People can find you. A general answer is that neurologic therapy is more likely at attached to a hospital. That's not always the best way. Sometimes they have long waiting lists and things like that. Can we provide, maybe there's an email that goes out after this, and we can provide some more resources so that we can send those to you? That might be a good way to do it.
Yeah, we can find a way. What
Okay.
about for telepractice? Are OTs limited to work with folks within their state, or how does that
Yes.
work?
Yes, you still need to be licensed in the state that you provide therapy in. So there are still some restrictions there. Imago Rehab is in 6 states. And there aren't a lot of, large telepractices that I know of, but if getting to therapy is a big challenge for you, it's possible that you could ask, if you're somewhere, you could maybe ask if they can see you over telehealth. You may or may not get a positive answer on that. It's still very new, and is really seen as a mitigation for COVID, but there's more to it than that.
Mhm. I think the biggest thing too is for patients with a neurological condition, when your doctor or when your doctor is either recommending therapy to you or you're asking for a referral, to make sure that you're asking for a site that does practice neurological rehab and not only orthopedic, like Kristin was saying, because you might come across people that are more used to seeing, carpal tunnel or fractures and sprains, and you really want someone who's working on that brain level and is able to work with you based off of what your condition is and what your needs are.
Absolutely. We hear that from clients. They were in their small town. They tried to go to the therapy place in town, but that's not what these people do. They're very skilled therapists. They do great work, but it's not neurologic brain work. So they found us online. So you're very right there. Yeah, we'd like to, maybe we can comment when it's on YouTube. We could make comments with some of these resources so that you have them. There are a few other questions.
Yeah, I think you already touched on this with the chronic piece, but someone was wondering, they mentioned that they've had a non-functional arm for 11 years now. Still a candidate for occupational therapy?
100%. Our furthest
Absolutely.
post is our patient who's the furthest post is 15 years post-stroke, and he just wrote his name for the first time post-stroke. So
That's amazing.
we're not gonna tell you it's too far.
No, and we had actually that study that I shared, we had a subgroup analysis that basically broke down someone who's 9 months post or 10 years plus post and the potential for improvement. And there was really no statistical significance in the opportunity for gains. So I had a patient who just did a Vivistim protocol, and she was 21 years post-stroke. So at the time, and her stroke was in 2002. So it is never too late to try a new thing, to see what new technology is out there, what new therapists have, new ideas. So we would always recommend to go back to OT for sure.
That is so inspiring. And everyone wants to know, will their health insurance cover this? What do you think? The technology, telepractice, in person, et cetera?
Yeah, I'll go first. So our telepractice is, covered by insurances like Medicare, Blue Cross. That's super important to us. Part of that problem statement I said was people don't get enough rehab. Part of that is accessibility through having the services paid for, right? So that's really important to us, and our device is not on the market yet. So we also want to make it very inexpensive so that it can be accessible. And there was a question about being able to put it on. And we designed it so that people can put it on by themselves in less than 5 minutes. That was like 2 years worth of research work. So very important. You have to be able to afford something, be able to access it, and be able to put it on your body. So
of course. And a similar thing with Vivistim. So we do have Medicare pass through. Medicare chooses a few technologies each year to have pass through to allow technology to be more accessible. So if you have straight Medicare and you are a functional candidate and a good surgical candidate, you're covered through Medicare. All other insurances like Medicare Advantage or commercial plans just go through a prior authorization process. So if you have specific questions about that, always reach out to a local Vivistim employee. You can always go to the website and contact us. But yeah, we work with all different types of insurances.
Great. And I'll share your websites here. It is 8 o'clock. So just to respect everyone's time, we're going to wrap up here. But we have the website for Imago Rehab and Vivistim. So Becca, Kristin, thank you so much for spending your time with us tonight and sharing your expertise and information about occupational therapy. I think we all learned a lot tonight. And thank you everyone for submitting the questions. For more information about the National Aphasia Association, and you can find educational materials, resources, information about providers and supports in your area, visit us at aphasia.org. We have a number of virtual events scheduled throughout the month, which are open to people with aphasia, care partners, clinicians, and you can find that info at aphasia.org/online-events. And next month, our Ask the Expert webinar is going to be Thursday, May 9th at 7 p.m. Eastern Time. And we're going to be joined by Dr. Jillian Velmer from Sing Aphasia. So definitely tune in for that. And If you have any other questions, you can email them to answers@aphasia.org and we will get back to you. And you can email any comments or feedback or suggestions about the Ask the Expert webinars to me at Catherine@aphasia.org. So thank you all again for joining us tonight. It was great to have you all. We look forward to seeing you again next month. Take care.
Thank you.